All right, let's get right into it. We're talking about a really critical shift that's happening in nursing right now. It's this big move away from just memorizing cultural facts and toward a new way of thinking, a framework that puts patient safety at the absolute center of every single interaction. It's really about changing how we think so we can fundamentally change how we act.
So start with this number. Just let it sink in for a second. 80%. What if I told you that 80% of a patient's health outcomes have almost nothing to do with the actual medical care they get in a hospital or a clinic? 80%. That single statistic, well, it changes everything, and it forces us to ask a really important question.
And that's the real challenge, isn't it? If the root of a patient's problem isn't something you can see on a lab report or a scan, if it's social or economic or environmental, how in the world do you even begin to treat it? How do we, as nurses, make that invisible 80% visible?
To answer that, we've got to map out what's actually in that 80%. We call these the social determinants of health, or SDOH for short. You can think of them as all the invisible forces that are shaping your patient's life, long before they ever get to you. And trust me, understanding these isn't just some academic exercise. It is the absolute foundation of safe nursing practice today.
Because when we ignore those social determinants, this is what happens. We get a health disparity. And just look at this example, it's so powerful. Black women are actually less likely to get breast cancer than white women, but they are far more likely to die from it. That terrible gap, that's not biology. That's a system failing them. That is a health disparity in action.
So to make this really practical, we can break down all those social determinants into these big 5 categories. This is your mental checklist, okay? Your assessment tool. For every single patient, you should be asking yourself, what's their economic situation like? What about education or language barriers? Can they even get to their appointments? What kind of neighborhood are they living in? And, what's their social support system look like?
Okay, so let's put this into practice. Here's our first checkoff question. You've got an elderly patient with heart failure. The medical side of his discharge plan is perfect. But look at his social situation. He lives way out in a rural area, he doesn't have a car, and he's on a fixed income. So what is your absolute #1 priority to keep him safe when he goes home? Really think about the root of the problem here.
And here we go. The priority is not more medical teaching, it's assessing his access to food and transportation. And the why is so important. Teaching him about a low-sodium diet is completely pointless, and honestly, it's unsafe, if he can't get to a grocery store or afford the food in the first place. Tackling the SDOH, that is the priority safety intervention. It's the thing that's actually going to prevent him from coming right back to the hospital.
So we've looked at the patient's external world. But here's the twist. You can't see that 80% clearly if your own internal lens is foggy with bias. So now we have to turn that lens inward, on ourselves. And this leads us to a really huge concept for safe practice. The shift from what we used to call cultural competence to what we now call cultural humility.
Yeah, the old way, cultural competence, it kind of felt like a checklist, right? I've learned the top 5 facts about this culture, so check, I'm competent. The new standard, cultural humility, is totally different. It's not a finish line you can cross. It's a lifelong process of self-critique. It means you walk into every patient's room with the mindset of, I don't know your story, please teach me.
And the biggest reason for the shift is the very real danger of implicit bias. Look, these are just unconscious shortcuts our brains make. It's not about being a bad person, it's just how our brains are wired to handle a ton of information. But in healthcare, those shortcuts can be a massive threat to patient safety. They can lead us to make biased decisions or give lower quality care without even realizing we're doing it.
All right, check off question number 2. Picture this. A patient is shouting in a language you don't understand. Your immediate gut reaction, your implicit bias is telling you this person is dangerous. So what is your very first move according to cultural humility? And notice that key word internal. What's the first thing that has to happen inside your own head?
The correct action happens before you do anything else. You pause. You stop. And you have to ask yourself, wait a minute, what assumptions am I making right now? This is cultural humility in action. It's that moment of self-reflection that stops you from just acting on a stereotype. It forces you to think, okay, is this really aggression or could it be fear? Is he angry or is he in terrible pain and has no other way to tell me? That internal pause, that's a safety mechanism.
Okay, so you've assessed their social factors and you've checked your own internal bias. Now what? How do you actually connect your medical plan with the patient's reality, especially when they're different? Well, you need a tool. And one of the best tools we have for this is called the LEARN model. Just think of it as a step-by-step guide for respectful negotiation.
Let's just walk through it real quick. First, you listen. You shut up and you listen to how the patient sees the problem. Then, you explain your medical view. Now, here's the crucial step. You acknowledge where your views are different and where they're similar. From there, you can recommend a treatment plan, and finally, and this is key, you negotiate that plan together.
Okay, let's focus on that acknowledge step, because it's usually the hardest one. Here's check-off question number 3. Your patient has a hot/cold belief system about health. He thinks his high blood pressure pill, which he sees as hot, is going to make his headache worse, which he thinks is caused by too much heat. You've listened, you've explained. Now, how do you correctly acknowledge his belief without lying to him or just dismissing it?
This is such a brilliant technique. The best action is to validate his feeling, not the scientific fact. You see the difference? You're not agreeing that the pill is literally hot. You're validating his experience by saying, I understand you feel heat is part of this. Then, you immediately pivot to your shared goal, and we both want to get rid of this headache. It's amazing. That 1-2 punch of validating and then pivoting, it builds the trust you need to negotiate.
So this brings us to our last section, and it's all about the non-negotiables. These are the hard and fast rules. When you're dealing with language barriers or low health literacy, there are very specific safety standards we have to follow to prevent serious errors. This is all about closing that communication loop.
And let's start with the biggest one, what we call a never event. You never, ever, ever use a family member as an interpreter, especially a child. I mean, the reasons are huge. They don't know medical terms. They might change the information to try and protect their loved one, and it's a massive violation of the patient's confidentiality. Just don't do it.
So, the rule is you must use a qualified professional interpreter. And when you do, there's a right way to do it. Number 1, look at and speak directly to your patient, not to the interpreter. You're having a conversation with the patient. The interpreter is just the vehicle for that conversation. And number 2, use short, simple sentences. No complicated medical jargon. This helps the interpreter be as accurate as possible.
And finally, here's your ultimate safety check, the teach back method. This phrase right here is gold. But notice the wording. I want to be sure I explain this clearly. This is not a quiz for the patient. It's a test of how well you taught them. If they can't explain it back to you, the responsibility is on you to try explaining it a different way.
Okay, final check-off question, and this one's a big one. The official hospital interpreter service is down. You have to get consent for an urgent procedure. The patient's daughter, who happens to be a nursing student, offers to translate to help save time. What does your commitment to safety and the law require you to do right now?
The only safe, legal, and correct answer is to delay the consent. Look, according to the national CLAS standards, these are the federal rules, a legally valid informed consent cannot be obtained through a family member. End of story. Safety and the patient's legal rights always win against convenience. It doesn't matter that she's a nursing student, she is not a qualified impartial interpreter.
And that really brings it all home. Think about this. The very next time you walk into a patient's room, remember that every interaction is a test. Are you just going to treat the symptom that's right there on the surface? Or are you going to take a moment, look deeper, for that invisible 80% and try to solve the real problem?